Right, good afternoon, gentlemen. I should say at the beginning of this session that we're expecting there will be a vote on the floor of the House at 3:30. So when the bells jangle, we shall disappear and return. Could I ask you just to begin by introducing yourselves briefly?
I'm Kingsley Manning. I'm the chair of the Health and Social Care Information Centre.
Max Jones, Director of Information Analytics at the Health and Social Care Information Centre.
I'd like to begin, if I may, because we had a session with you, I think, Mr. Jones, and also with representatives of NHS England 3 or 4 weeks ago. And it was very unclear to the committee then how HSC Information Centre relates to NHS Information Centre, the forerunner organisation with a surprisingly similar sounding name and function. And can I ask you to begin by explaining the extent to which the HSC Information Centre has inherited the structures, the people, the decisions from NHS Information Centre, and the extent to which its scope is different or the same as its predecessor organisation?
Certainly. As you know, we were formed on the 1st of April 2013 under the Health and Social Care Act, and I suppose the three major and significant components of us are the old NHS Information Centre, and I'll come back to that in a second. We also took on board the Connecting for Health, which was at that point a part of the Department of Health, and we also then subsequent on NHS Choices, and we also took on the implementation teams around LSPs, the local service providers. This is about the end of the national programme from the special health authorities. So that to give you a sense of numbers, the NHS Information Centre employed about 500 people, the Connecting for Health employed about 1,350 people, the LSPs from special health authorities about 200 people, and NHS Choices about 150 people. So we started off in April last year with about 2,200 people, of which the NHS Information Centre was 500 people. So our broad activities under the Act are to provide information systems, including the physical information systems such as N3, which is the national network, the spine, which is a very key component in terms of running the system, for the collection, storage, analysis and dissemination and publication of information across the system as a whole. So the Information Centre, which is 500 people, we've inherited its duties and responsibilities, although they've been rewritten in the Act. But it is one part of what is now an organisation of 2,200 people.
But all of the functions of the old NHS Information Centre have been carried forward to the HSC Information Centre?
Yes, although there's an important shift and change, which is that we have an explicit requirement under the Act, the 2012 Act, to act in the interest of the health and social care system, whereas the Health Information Centre collected information, disseminated and published it in pursuit of its function. So we have a much tighter and a much more specific remit with respect to what the basis of our actions are concerned. And the primary, by the way, it's just worth saying, the primary function or the primary role of the NHS Information Centre is around, for example, providing the national statistics. We publish 400 odd reports a year on health, as well as publishing the data sets and the data sets we're going to talk about today. So it's a broad range of activities.
But leaving aside Connecting for Health and the other activities, what we're interested in today clearly is the availability of information and the manipulation of information and the controls on the manipulation and making controls on access to information. That was a function that was previously a function of LHS Information Centre and is now a function of the HSC Information Centre.
It is.
And there's other activities in your organisation that were not in the NHS Information Centre.
Yes.
For the purposes of this inquiry into manipulation and controls of access to data, that was a function of the old Information Centre and it's a function of the new Information Centre.
Yes.
And so then the next question is, what change is there in the governance between the old Information Centre and the new Information Centre, or are they, for different statute but practical purposes, very similar?
I think I think practical secretaries, they're very similar, but the functional definition of what our what we're required to take note of has changed. And
that was your point about, you said that the new law allowed you or required you to take account of the to focus on the system. It wasn't clear to me what the old law was.
Do you want to quote
it? From the original 2005 Health and Social Care Information Centre directions, and it lists some generalised functions for the old IC, but it specifically states that they may exercise functions to do anything whatsoever which is calculated to facilitate or is conducive or incidental to the discharge of the information centre's functions. And that's in contrast to the equivalent clause under the 2012 Act, which forces us to take account of being in the interests of the English health and adult social care system. So it shifts the focus to the purpose of being to the benefit of the system as opposed to being for the benefit of the organisation.
All right. But beyond that, there was no substantial change in the legislative formula for the information centre.
There was a significant expansion of many of the features which were outlined in relatively little detail in the 2005 Act, but were expressly stated in many of the clauses under the 2012 Act.
Okay. And in terms of the governance and the individuals carried forward from the old organisation to the new organisation, there were 500 people in the new organisation. They were inherited by and large from the old organisation, presumably.
So, and of course, just for completeness, the NHS Information Centre was a special health authority, and we're clearly an arm's length body of the Department of Health. So there was a governance structure.
But in terms of what patients or the policy community look to the information centre to deliver is access to information subject to proper safeguards.
Yep.
The old information centre made decisions, and the new information centre makes decisions about that, and the formulations have changed, but the basic approach hasn't.
We would argue that because of a series of if you like, contextual factors, the overall approach has changed because we have changed it by taking a different approach, a more robust approach. When I became chairman in June last year, it was clear that the approaches that had been adopted by the Information Centre were no longer entirely appropriate, given both the degree of data we were being able to collect, a change in public expectations, and it was also clear that some of the processes that the previous Information Centre had been operating were not as transparent or as consumer friendly, if you like.
Well, now we're getting somewhere, because in the previous, what irritated some of us, I think, in the previous hearing was the answer to the question, what are the controls around access to information, was on more than one occasion the answer offered was that was a decision taken by the previous organisation. But actually, from the beginning, 2005, I think it was, of the old Information Centre, it seems to me that if we're going to develop broad confidence in the security around the handling of information, a narrative, to use that overused word, that you were just suggesting, Mr. Manning, that said what used to be wasn't right, and we've taken a series of steps to tighten it up. That's a different narrative from the one that says it had nothing to do with us, Gov.
Oh, I agree entirely. I mean, as you know, we're committed to we've undertaken a review. We are undertaking a review to look at all the releases put by the IC. Our initial trawl through that suggests that they were acting in a completely proper process, but it was in the context of the time and the context of the rules they were then. I simply felt, and I think our colleagues on the board feel, that the time's moved on. The security threat is much greater, the volume of data is much greater, and the public's confidence in public bodies to handle data, not just us, but across the whole of the public sector, has significantly changed. And the processes that were run by the IC were proper in their time, but were confusing. I mean, trying to define the difference between DAG, IAG and CAG and IGOP, and I'll come back to all those acronyms later, is very difficult indeed. And that we didn't have processes that were, as I said, consumer or citizen friendly, and that's what our intent was from the start.
Barbara, go on.
I just wanted to actually quickly ask you about the licences under the old system. Have they ended, or...
You mean the agreements that on data sharing?
Yes.
And this will be confirmed in Nick Partridge's review, which we'll publish at the end of May. But so the figures may slightly change, but I'll give you what we know about at the moment. We think that as of April 2013, there were 249 organisations that had extant data sharing agreements issued by the NHS Information Centre. Just to remind you, and I'm terribly sorry, this is overwhelmingly complicated and particularly this data sharing agreement apply to where we are issuing pseudo-identifiable anonymized data or identifiable data. This is where there is a theoretical risk of identification. So that's where we have data sharing agreements or data reuse agreements in place. There were 249 in April that had been issued by the NHSIC, of which on April this year there remain 112 of those. So they're running off as we go forward.
So there's an end date. And can you publish who's actually got who?
We will be doing so at the end of May. And of that. Just by the way, just so you're clear about this, of the 112 that still have data sharing agreements with us, none of them received, in fact, any data during this year. What those data sharing agreements will do is cover the data they were issued with during the period of the NHSIC, and will make sure they're still bound by the same requirements that were issued by the Information Centre at that point.
I've got a more detailed question about those shortly, but can we just go back to this NHSIC and HSCIC, because there has been some confusion, which I've commented on in the chamber here, in that at the end of the session, the last session that we had, Max Jones was asked by a member who isn't here about this point, about staff transferring across and decision makers transferring across. She was most specifically asking if some of the people who'd been decision makers in the NHSIC were now decision makers in the HSCIC. You said, and I can quote you, the very senior management in the HSCIC is not the same as the very senior management that was in the Information Centre. That doesn't seem to me to be true, because I then had an answer from the Minister that 3 of the non-executive directors and 2 of the executive directors were previously members of the NHS Information Centre, including, of course, Dr. Mark Davis, who'd been in both organisations and who was, for instance, last year chair, until recently, chair of the DAG. So how did you come to say the comment that you made? Because you've since written to us about it, and I have to say I'm not happy with your letter.
So I did write to the committee. In that previous discussion, we were talking about the senior management who had responsibility for decisions and accountability for decisions on data sharing. At the time of the committee, the executives with responsibility for that were myself for data and information services.
No, can I take you back to what you said? You said the very senior management in the HSCIC is not the same as the very senior management that was in the Information Centre. Now, that doesn't seem to me to be true. Because Dr. Mark Davis was a very senior manager, wasn't he?
What I was attempting to say at that time was that if you looked at the very senior management of the old IC and you looked at the very senior management of the HSCIC, they are not the same. And specifically in the area of data access and control, then myself and Rob Shaw were the 2 executives with responsibility and accountability for data and information sharing and CSIRO responsibility. At the time of the last hearing, Mark Davis had attended his last DARG meeting and was not the chair of DARG for the meeting that took place 2 days later.
The member wasn't asking you about that day of the hearing. She was actually referring back to the releases to insurance companies. That's what we'd been talking about. We'd been following a track of questions around who had been responsible for data releases in the past. For many months, since he transferred across from the NHS Information Centre, Dr. Mark Davis was chair of the DAG and was in that senior position. In
Absolutely,
fact, in
yes.
terms of in
Yes.
terms of data sharing, I understand he went on the trip to the United States with the Secretary of State and was there when they signed the Memorandum of Understanding. So he was clearly a very senior manager in that organisation.
But not at the time of the hearing when I made my statement.
He was.
So
he was. It was the,
no, but
it was the 25th of March.
He was not the chair of DARG, and he was not the senior information risk owner, who is the accountable member of the board with responsibility for signing off data sharing
I'm afraid
contracts.
that isn't satisfactory. The member was trying to get to a broad understanding of the people who were decision makers in both, because what was happening in that meeting is there was a lot of wriggling going on about nothing to do with Osgov. This all happened in the past. Now, I mean, to me, to have answered the question in that way is this person was a very senior manager, to the extent that he accompanied the Secretary of State when he went on a trip to the United States to sign a data sharing memorandum of understanding. It's astonishing that you say the person who'd been the chair of the DAG didn't have that responsibility, and that you're still wriggling to try to get out of that now. I'm not happy with that answer, Chair. I just don't think that's acceptable.
I'm sorry. We're trying to be as transparent as possible. Can I just?
Well, I don't think so.
I
really don't think so.
Can I just talk you through what the history of this, and so you perhaps get a sense of it. When I was appointed on 3rd of June last year, I was the only director who was not an interim appointment. All the senior management and all the directors, including all the directors, were interim directors. We therefore had a major transformation to undertake. Part of that was reorganisation of the management team, and we took the view very early on that the current management of the data sharing arrangements and of the IG functions needed to be changed, which is why we made Rob Shaw, who'd worked for Connecting for Health previously, not the IC, the CIRO, the Senior Information Responsible Officer, and we made Max responsible, we made Max responsible for the IG functions and had reporting to him. So we changed dramatically, and that was undertaken in September. At that point, we knew that Dr. Davis was redundant. He'd been made redundant on the abolition of the Information Centre, and we put in place a plan to deal with that. He was in post. We weren't in a position that we had to.
Sorry, you had a plan to make him redundant last year.
No, he was made redundant by virtue of the abolition of the NHSIC. It wasn't our decision.
So you kept him on for 8 or 9 months.
We kept him on because we needed to have cover on clinical governance and on clinical advice.
So in fact, he was a very senior manager, and he did accompany the Secretary of State on the visit when they shared the memorandum of understanding.
Well, in fact,
and he was let me say a bit more.
I was there
This is
also.
a person that you were making redundant, but you let him chair the DAG, and he made decisions, a number of controversial decisions, including he made the decision out of committee to release the sensitive medical records of individual teenagers on the national.
I'm sorry, that's not true, I'm afraid.
Well, it was reported to be true. And
no, I think you're referring to the fact that he was asked to give advice by Cabinet Office, and he'd actually worked for Cabinet Office on the matter. He gave advice on the consent model that they were going to use. We never released any data, and we've not been asked for any data by Cabinet Office on this matter.
So this was reported last summer by The Guardian newspaper, that the sensitive medical records of teenagers on the National Citizen Service were released, and that was apparently an out-of-committee decision by the chair. Dr. Mark Davis was allowed to make decisions as out of committee as the chair, and that decision apparently took part last summer.
I can clarify that that Mark Davis did provide advice, as is one of DARG's functions, on the consent model, which was being considered by Cabinet Office in this area. But we have not received a request for that data, nor have we provided any data. And the discussion which Mark had was referenced and recorded in the January, I think it was, I'll check in a moment, January DARG minutes.
At least 6 months after the discussion took place.
That may be the case.
So this is a person that you're going to make redundant?
But no data was requested nor shared. Advice was requested on the consent model, which was given.
What was requested was linkage of data, wasn't it? It was linkage to medical data.
So he was asked by Cabinet Office to give professional advice on the consent model they were considering. He gave that advice, which was a perfectly sensible thing to do. That was the end of the matter.
And that was recorded in the minutes of DARG.
Yes, I have a copy of that in front of me, but I think it would have been sensible, and you talked earlier, and it's quite important about transparency, to have recorded this 6 months after it happened, and to then be trying to change something. I'm not aware that that the Guardian was challenged on the fact that data had been released. It seems there's a very hurried, after the event style of things happening here, and that's not good for transparency. This is actually really being talked about quite a bit, and I think in terms of confidence being undermined, people's confidence in what you do has been really undermined by this. One, that there could have been any suggestion of linkage to medical records for those people taking part in the National Citizen Service. I mean, for heaven's sake, that there are all kinds of undertakings made to them as they sign up in terms of that service, and quite rightly. In fact, they even have an opt-in for their personal data there. So to even consider that, not to have documented what was happened until 6 months after the event, just makes you look shady, I'm afraid.
Well, I agree, Ms. Kelly, but we didn't have a data request and the data release. I absolutely agree, by the way, with your essential point, which is the sensitivity of linking this data in any way with receipt of data, benefits or rest of it. One of the things I noticed in our press release last week was, in fact, we welcome the proposition under the Care Bill amendments that will bring CAG into this, the Confidential Advisory Group. And one of the areas we think that they should look at is indeed the extent to which we share or should share data with other government bodies. This is an area where there is lack of clarity, and I think a great deal of sensitivity. We know from our own research, by the way, that one area where we have absolute sensitivity is in this. People are very, very worried about the use of their medical records in any way which might have an impact on their tax returns or on their benefits payment or on their housing allowance, any of these things. So we think this is where we would very much welcome the advice of Parliament and CAG to the extent to which this is possible. At the moment, as you know, we haven't released any data to DWP or any such body, but we absolutely recognise that it's a key issue.
Well, commercially, people have got that information. There's DVDs out there with all that information on, yes?
So what information?
Well, you provided DVDs to external customers. I'm sorry, somebody else is going to ask you about that, but there is information out there. We had evidence session, well, I don't suppose you'd describe it as an evidence session, more a tutorial, where it was very clear. I put to one of the people present, could he locate my medical records? He said it would be illegal for him to do so, but should we get permission, he would do it immediately. And so he's not making it up. And he said he could identify all of us. In fact, I asked him, could he identify the Prime Ministers? And he said within 5 minutes.
I can't, it's difficult to comment on this. First of all, we've gone through in great detail the process of releasing the data that we have been responsible for, and we're going to follow that up with the data that's released under the data, under sensitive data. As you're aware, we release as part of the open data agenda a very large amount of anonymised data, where it would be impossible to do that. The use of, or any attempt to use any of the data we issue, which is pseudo-anonymised or identifiable data for the purpose you suggest, would be clearly in breach of the law and would potentially be liable for a £500,000 fine.
And if I'm a big pharmaceutical company, that's going to worry me, is it?
Yes, I think it absolutely would.
Oh, rubbish. Where we need to get to is, unless you can back this up by saying, if you're a chief executive and you've misused the information, anybody in your organisation misuses the information, then you should be liable for a prison sentence. And until you do that, saying we're going to fine you is a load of old rubbish. And if I were you, I'd be ashamed to be chair of an organisation that even potentially allowed that to happen.
But the power to put people in prison is way beyond my pay grade.
No, absolutely, but why do you sit there comfortably thinking that everyone's going to be good because we're going to fine them threepence? Rubbish.
If Parliament we absolutely servants of Parliament on this. If Parliament wanted to change the regulations with regard to the release of data, we will clearly be happy to do so. We have put in place the safeguards and the processes that fulfil and meet our obligations. We have no record, and we would be very happy to meet anybody who has evidence of people who have identified individuals using pseudo-anonymised data.
I can my colleagues are here. I can categorically assure you that providing we could give indemnity, there was a person who came here who said they could do it in minutes. Is that not right? Is it true or not?
It's what he said, Rosie. The committee is also used to having people saying things and expressing opinions as well as facts.
Well, why don't we demonstrate it? How do I get permission for him to identify
I think that's a question for the clerk rather than the witnesses. Barbara.
I think Valerie just had a follow-up question.
Just some of the follow-ups. I think you've obviously gathered from the number of sessions, Mr. Manning, you weren't here at the first session. We had Mr. Kelsey, who doesn't appear to be here today. I don't think he was invited, but you did write to us, Mr. Jones, with Mr. Kelsey, and I'm not sure, just really following up my colleagues, we're not quite sure that the answers are very helpful. So I was just wondering if you could turn to the letter and I could just ask you some information about them. So it's very concerning, and I hope this is going to be published on someone's website, either your website or certainly the Health Select Committee website, so people can see some of these answers and follow them up. If you just go to the first one, the copyright on data used in the Institute and Faculty of Actuaries report. I mean, it's sad in some ways, isn't it, that it is going to be public, but actually looks like you don't know what you're doing. So a logo's being used and you didn't know it was going to be used. But do you want to look at the answer?
Yes, I'm just trying to locate that. Well, sorry, I am aware of the answer which we gave. I mean, the organisation used our logo without coming to us to seek our permission to do that. They were entitled to have access to that data under the agreement which they had, which was granted by our predecessor organisation, and under the terms of that agreement they were required to show a copyright statement in their publications.
Right, and so this is the difficulty, isn't it? You say you didn't know, but if there were proper procedures in place, they would know that they had to ask you, wouldn't they?
Under the data sharing agreement, they should have done.
Right, okay. So why isn't the, well, where is it? Is it in there?
Sorry?
Is it in the data sharing agreement that they should ask your permission?
We're very happy to share the data with you.
Is it in it or not?
I don't know on that particular...
Right, this is what I'm trying... I think this is what we're trying to say. You come here... Hang on a second. You come before us. We have been elected by the public. We are here to hold you to account. And when things go wrong, as they appear to have done, we are entitled to ask you questions. And I am absolutely appalled, and I think the majority of us are appalled, which is why you're back here again, to try and work out why it is you don't know what's going on in your organisation. And this is a simple thing. It's either in the agreement or it's not. They either have to ask your permission or not. They can't just use it. And you've made it clear here that you don't know. Is that right or wrong?
Well, they have to include a copyright statement.
But you don't know, because you said it in your answer.
They're required to do so, and
right,
they used...
And they didn't. And so what have you said to them?
So they're required to use a copyright statement, and they clearly used the current logo when they should have used the previous one.
Right. Correct. So people are going around doing things as they wish, without checking with you?
Well, I don't think you can equate which particular image and logo an organisation uses with the...
well, it's the stamp of approval, isn't it? That's the key thing, isn't it? It's your stamp of approval. You're taking people's data and then it's being used in a certain way, and that's the stamp of approval. And what the public and we all expect is that there are proper procedures to ensure that the release of data is adequate and has proper protection. That's the point, isn't it?
Well, I think the public has the right to expect that they should see us do things which will encourage their confidence, to help transparency. I can see that on this case, this discussion does not enhance confidence in this area.
Right, and this is what our job is, to do that.
Nor are we saying that in this particular case, any data has been released in an untoward fashion, in an illegal fashion, nor that patient confidentiality has been threatened.
Well, whether that's the case or not... Let me just take you, because it is regarding the Institute and Faculty of Actuaries. I'm trying to tease out, you mentioned that you're an arm's length body, but how do you allow a minister to go into the chamber to make a statement which is wrong, and then she has to, oh, you don't know, you're actually mentioned in her statement, in her letter. Do you not know about what the Minister, Public Health Minister, wrote to the chair of the committee on the 3rd of March?
I don't think I'm cited on that.
She thought that the information that was released, you haven't had sight of that. I was made aware on Friday the 20th of February, that the information I had on hand during the debate did not include the latest clarification received from the Health and Social Care Information Centre. That's you, isn't it? HSCIC?
It is.
Right, okay. I therefore wrote to you on Friday to inform you of this and to seek your steer on how best to correct the statement that I made in the debate. The correct position, you don't know any of this.
This isn't ringing any
This
bells.
is about you, your
organisation.
organisation, and the Minister's gone into the chamber to say the correct position was that the faculty requested pseudonymised information and that the faculty said they would publish this only as anonymous information with all identifiers stripped out. I can go on, but in handling this request, the NHS Information Centre, that was the predecessor organisation to the current, did not treat this as a request for sensitive information. I think you should have a look at this.
We're happy to do that and come
what
back,
is the relationship?
come back with a note to the committee.
So just to help me with the relationship, the governance relationship and the accountability between yourselves and the Department of Health and the Minister. You don't know that a debate is going on about Care.data and information that, discusses you. What is it? When there are questions coming in, do you answer them? Does the Minister ask you for information?
We get regular requests from the Department of Health. We're not privy to ministerial statements before they occur.
I'm not talking about ministerial statements, I'm talking information, facts.
We will respond clearly to anybody who asks us for that information, including the Department of Health. Right.
So you sit in your organisation and you kind of have your own governance, but you don't have any link to the Department of Health or the Secretary of State?
We meet through a process of accountability through the sponsor department, and we do that periodically. And a number of things we work very closely with them. But we are an executive agency, we're an arm's length body. We don't have a day-to-day presence from the Department of Health in our offices, and there's no necessity necessarily for them to have discussed this with us before they published it.
Well, there is, because normally in the civil service, when there's a debate about something, civil servants will prepare a report and they will find out the information and they will give it to the Minister. So the Minister tells Parliament the correct position. That's not happening here, is it? So a Minister can go into the chamber and say something which is totally wrong, and it doesn't really matter, does it, to you?
I think it matters enormously.
Well, then what are you doing I'm just staggered that you don't know that this has happened. You don't know that a Minister has made an incorrect statement in the chamber and has had to write to the chair of the committee.
I was aware that that Minister had corrected the department. I was not aware, as far as I can say, we were not aware that the original statement, and we were not asked to prepare it. We're not asked to prepare ministerial statements.
And so this is where I say that the governance and the accountability is falling down. You can stand behind an arm-length body, but you are operating separately with no accountability.
Well, we are accountable.
You keep frowning, but I'm just trying to paint a picture for you.
I understand that you
I know you've come from an organisation outside the civil service and you don't understand the public interest. I know you don't. You can't possibly, from years and years of people being in the civil service. You're there as an arm's length body to do what it is you like and forget about what happens to ministers and forget what happens to the general public.
We have I agree. I understand you may not appreciate the current structure of the accountable bodies. We have an accountable officer in the Chief Executive who is ultimately accountable to the PAC. We have an accountable relationship with our sponsor branch within the Department of Health, which results in us having a monthly meeting, which is formally, and I meet with the Permanent Secretary on a monthly basis. That is the nature of an arm's length body.
Right.
And we are accountable then through our attempt to be as transparent as possible to the public and to Parliament.
And our concerns are, because you say you are, our concerns are is that you've got people's public data, people's information, absolutely important information about every single aspect of their life. You have that, and you are an arm's length body, and that's what concerns everyone. There is no accountability.
No, hang on a second. We're accountable, firstly, as I said, to Parliament and to the Department and to Parliament, and we are here being held accountable. And we're also governed.
I don't think you're here being held accountable. We've asked you to come back because we were unhappy about some of the answers that you gave
actually,
about the shambles in your organisation. It is. Well, I haven't finished. I can go on.
May I just say that we're delighted to be here. And in fact, as the Chairman will tell you, I actually visited him in January asking to come and talk to you about the work of our organisation and to discuss with you our activities with release of data.
With the greatest respect, we don't want to talk to you or discuss. We want to ask you questions and we expect answers. If you were here at the previous hearing, you would know that every question we ask, basic questions, basic information about how an organisation is run, the answers were not available, hence this letter. And if you read this letter, it doesn't even say yes or no, it doesn't even answer the questions properly.
Could I... There's some detail on this which I think is quite important. Part of the difficulty in media and social media is that there's a real difference from your pronouncements. What you say is the situation with data and what the people out there, commercial organisations who have HES data, who already have those very large databases, are saying. So if we go back to the insurance actuaries, the Staple Inn Actuarial Society, these comments are from the report that they produced on the use of 188 million records taken from HES. They talked about the data as being highly detailed. So we get an answer back that says that the data is in aggregated and anonymised form. And they say, after they have actually run all the things they wanted for commercial reasons against hospital data, and don't forget the HES database started off as an admin database for handling payments to and information about patients. It was never set up to feed into the insurance industry, was it? They say the HES ID allows all instances of care for a patient to be identified and linked. They lay out all the ways, all the specific details that there are in individual records: clinical information, demographic information, age and gender, dates of admission and discharge from hospital, location of treatment, the area in which the patient lives. In fact, they say that the data contained 47.5 million unique HES IDs compared to an English population of 49 million. Very close echo, of a one-for-one in the records. And they're not the only ones who say these sort of things about it. Harvey Walsh has been running a database and says that it provides NHS data out to the pharmaceutical industry. There was the issue a few weeks ago with the tool by the firm Omega Solver. There's been the issue about PA Consulting putting up all of that data, that massive 13 years of hospital episode data, onto Google servers, onto the cloud, and real worries about security there. All of these people don't say that they've got aggregated anonymised data. They say they've got very detailed information. It comes back to the point that my colleague was making. What is being said to us by specialists, what has been said to us again and again, is that it is possible to re-identify people. And in fact, Dr. Mark Davis has said a couple of months ago, I think, that it was possible. There's a small risk, if you have enough data, that you can re-identify patients. We've had examples given to us in the House of people who, an MP who's had his nose broken 5 times and thinks that makes him, in terms of his hospital records, a person who stands out. There are individuals in public life who've had well-publicised operations and incidents, accidents, and about whom there will be a lot of data. What I read out to you that the Staple Inn Actuarial Society said, that's very detailed information. And yet you have given answers to ministers that they have used, that my colleague was talking about a few minutes ago, that just make it seem like this is not data of that type. The users are saying the data is highly detailed. We can build up an individual's medical history across all episodes, and we can link all their diseases. That's what they're saying, the users of these data. So for a couple of £1,000s, you have put out 188 million records, or in fact your predecessor did. And now this is the case. Now this is being reported, this is being commented on, this is making people feel undermined. So you are saying one thing and ministers are saying one thing. What the information that's out there is totally different to that. That looks very detailed. I have seen screen grabs from the patient analyzer tool that show that very detailed picture. It's almost possible, it feels, to identify a person, when they were admitted to hospital, where they live, what their age band and gender. It's very, very detailed information. Why this difference between a kind of pretense that this is all aggregated, this is all anonymised? When we were told in a seminar, and people are outside of here are saying it is possible to re-identify individuals on this data. We'll come on to pseudonymisation.
No, sorry,
but
that
we
you
need,
are talking
we need
about
to know,
pseudonymised data, I'm afraid.
we need to know what is out there now. And there's a feeling, a very strong feeling, and I subscribe to it, that this data is not protected enough and it has been let go. Now, you know, it's out there. You mentioned that there were 249 commercial reuse licenses, of which 112 are left. But some of these people, some of the ones I mentioned, also are selling it on to other people. You know, that we've had lots of examples.
And if they have a data reuse agreement, that is perfectly legal for them to do so.
So there are, in fact, it may be that you've totally lost control of the data that's already gone.
Sorry, I'm terribly sorry.
You may have already lost control of the data that's already gone. It's out there. It's on the cloud. It's being used on different forms of computing.
Thank you for your explanation of that. We are required under the Health and Social Care Act to publish certain data, and we're required to disseminate data. I mean, that's actually one of our functions. We do so in a manner which is in accordance with the regulations and the law, and we believe is in accordance and overseen by the Information Commissioner.
Yeah, I've just written to.
Okay. We can't make up the law as we go along. We act within the regulations and law as it is. And we accept, and are entirely straight about this, there is a theoretical risk of re-identifying the small amount of the pseudo-anonymized data that we put out. That would be illegal to do so. We have no examples of where it has been done. I'd be delighted to meet the individual who says they can do it. It is a theoretical possibility.
But in fact,
detail of the data is, if I may say.
Can you just stop at that point now? Because you should almost say yet. I think the feeling that we got in our seminar was you have no instances of that happening yet. But I mean, I think it would be fair at this point, given what I've just said and the picture I've just drawn, for you to admit that you have lost control of the data that's already gone out of the NHSIC. It's gone. You have had these 249 commercial reuse licenses. Some of these people are not just having the data for themselves, they're supplying it to others in the industry that they serve.
And if they have a reuse agreement, that is legal for them to do so.
Fine. Well, I mean, so whether or not it should have been, that some people, and I know you're looking into this, have actually then loaded that very large amount of data that belongs to every patient in this country, or should do, onto Google servers. And so, you know, you can form your own opinion of how secure that is. I mean, this data has gone. You are not controlling that data at all.
We control the process of release, and in the register we published this week, we gave details of the legal basis for doing so, and we have done so in accordance with the regulations and the law as it stands at the moment. We've put in place a series of data sharing agreements and reuse agreements, which are overseen by the ICO and by the regulators, by the regulations, which make it illegal to re-identify anybody, even if the theoretical possibility exists, and which require the use of the data to be clearly stated, and there has to be a proper purpose for that, and for it to be destroyed once it's used. There is no question that this data is immensely rich and does allow you to look in great detail across the health and social care systems. That is one of its great asset values for the health and care system as a totality.
But stop on the proper purpose, because it's quite easy to see, and in fact, since you released the register the other day, there are a number of examples given there of companies. I mean, one of the companies wanted to. A lot of these are market-based ideas. They're not really driven by the health benefits to the patient. One of the companies said that its usage was to examine the UK uterine fibroid market.
Mm-hmm.
The word was market. I quoted an example to the minister in a recent debate I had of a company that was comparing prices and performance between consultants, and a kind of go compare type comparator of pricing per consultant. And you let the DAG released data, consultant data, sensitive data to that last year. So a lot of these uses, and when you say proper, do you mean you're just including that market uses, any market use?
The regulations as they stand at the moment do not allow us to make that type of judgment as to. I'm terribly sorry. You may find that amusing, but if you the amendments to the Care.data bill, the Care bill, slip of the tongue, Care bill will enable us to ask CAG, and in fact I've already said in public that we would welcome the advice of CAG with regard to these types of releases. However,
But you've already made them. So in
I
fact,
appreciate that.
You've established since you were since. Let me just finish this point.
We operate according to the Act as it has been passed. We make decisions on the basis of the current regulations. It's not our job to make a judgment on whether or not we agree or disagree with the nature of a commercial organisation. That is not a criteria upon which we act.
So you are prepared to release even sensitive data out to organisations who just want to do a price comparison website on different pay procedures between different hospital consultants, because that's what you did.
I'm terribly sorry. We're bound by, as I said, the law and the regulation. Under the current regulations, that is perfectly legal and legitimate. And indeed, it's arguable that it is a benefit to the health and social care systems as a totality. That's an argument which you and the Parliament and the public will have to consider. Whether or not there's real advantages in having efficient and effective suppliers such as Baxter's or any of these other companies, whether or not you want pharmaceutical companies to effectively use the data to develop new drugs or to develop new services, that's a decision you have to make.
But entirely commercial uses, like the insurance use, like the price comparison use, are two things. And the third area of concern I've got, if you just let me finish this point before you answer it, is that you don't control who the end user is. For all those companies that advertise their services just to an industry like Harvey Walsh and some of the others, they're just selling on.
They have to have a specific agreement to be able to do that, and that requires them to take appropriate steps to safeguard the data.
So have you got the information, because I've asked for this twice and not been given the information, for all of those 249 organisations with a commercial reuse licence, all the end users? Can we know who all the end users of our data is?
Because they're using it and putting it into additional services. So, for example, a company like McKinsey or KPMG will have used it to support Monitor or the NHS TDA in advising on the transformation of healthcare services.
All commercial clients, because
commercial clients actually were, I think it's worth bringing to the point that they were a significant minority over a majority of the people that we released data to, in fact, were part of the NHS.
But what we're talking about is audit. Can you audit? There are apparently going to be audits. Can you audit all the data releases? Can you say, with all of the HES data, where it has gone, who is using it, and for what?
No. And indeed, in terms of the anonymised data, which we make freely available on our website...
No, I'm not talking about anonymised data, I'm talking about HES.
I don't want to... we'd be specific. Pseudo-anonymised data is actually, in terms of the Data Protection Act, treated as being anonymised. It cannot be identified.
It's not the same. That's a really playing with words. It's not the same. I am not as protected when you issue pseudonymised data than when you issue anonymised data. I have had a drug company write to me and ask me to get involved in a trial because I've got a dodgy name. Well, how does that work then? So they know who I am. They know they've got. Does that qualify as anonymised? I've asked the data commissioner to look at it. I tell you what, the message you are giving, sadly, because I believe that there are huge health benefits from this that could be derived from it. The performance of the last team and what we're hearing today. The big message out there is, you talk about you haven't got permission for this or that. You haven't got my permission. You haven't got the permission of the great British public. Not all of them actually received your letter. You haven't got their permission to freely give their information out there. So the message is, if you want to protect yourself from a bunch of clowns, you need to make sure you opt out tomorrow. That's the message. And how sad is that? You're behaving as a group of people who haven't got a clue. You can argue about and pirouette on the head of a pin. You haven't really answered Barbara's questions satisfactorily. Can I just ask you a question? Let's stop me making a statement. The question, when did you know that your logo was misused? When did you know?
I'll have to come back to you with the exact date.
What did you... Hold on.
Yeah, that whether it was a year ago, 2 years ago, or 2 months later. You can't say that.
No, it was relatively. It was not long before the previous Health Select Committee, so I would need to come back to you with the date on that.
I'm sorry. I'm just follow up from the. It's a very important incident when that logo was misused, and you don't have the idea that when it happened.
Well, I can't today give you
we don't want
the
that
exact
it was
date.
on the 7th of April or 8th of April, but there must be that around that period we found out.
But I would say it was within...
Like very vaguely that nothing happened.
For me, I would say it was within a week of the last Health Select Committee, so that would be around the middle of February 2014.
Okay, so immediately you found out, what did you do?
I asked the team to investigate and to come back to me with further details.
And we're in the process of doing that.
And in fact, we've done exactly the same thing.
Forgive me, we're in the process of doing that. You're talking about February. Our logo was misused. Did you tell them to get it off their website? Did you immediately? You don't have our permission. You're like forgive me, I'm sorry to be, I can only be rude. You're behaving like this is all happening out with you and these things are happening and we're doing our best and it's all okay. It's not. And then you're telling me that you are safe to use the medical records. You've already messed up and misused the hospital records and now you want GP records. This is nonsense. If you can't get a grip, you cannot ask the public to trust you any further. It's absolute rubbish.
Would you like to respond?
Are we going to have questions?
Yes, why should we trust you when you haven't got a clue?
Well, you can trust us because I think, firstly, we have a record, a world-class record in keeping data security. There's been only one major breach of loss of HES data since 2009, and that was, in fact, in northwest London. We have a world-class record in providing data to support research.
You yourself said about 15 minutes ago that you have no clue who is using your database.
Where's the data going?
You
Who's
said
got
yourself earlier on that you have no idea who is using, in response to one of my colleagues' question that you don't have any clue, idea who is using.
I was making a distinction between, for example, our widespread publication of anonymized data. So, for example, last week we published on our website the prescribing data, for example, for December at GP level. That's freely available to anybody who wants to use it. We make no constraint on that. As part of our open data agenda, we're committed to make that available to whoever wants to use it. The same applies to about 400 other data sets.
I stopped you earlier, though, and said we're not concerned with the sort of the generalised data. We're talking about...
Yes, but if
I had given examples.
If I could answer the point, may I do so? If I may, that is overwhelmingly the amount of data that is made available. I realise that, and if I may come back to that, which is why, specifically with regard to the sets of data that are covered by data releases agreements, data sharing agreements, I took the view that the process that we inherited were no longer robust. We've been in the process, therefore, of changing the management, the processes, and we have voluntarily decided to adopted a process that would be much more transparent, both about the process and about the data releases we have made.
What I was trying to get to is the concern, and we're just looking for transparency, for honesty here. If you can't say, and I think you have said that you can't say with all the data that was previously released through these commercial reuse licenses, where there are end users, you're unable to say, the question that the committee wanted to put to you, what are the uses to which the data released under those licenses may be put, what controls are in place, and what information is provided? You don't know, because if the whole 13 years of the HES database, however many million records, has gone out to one of these providers who then provide on to others, and in the United States this has been putting up the data on Google Cloud, and we're not sure of the security of that, it has been so, then you can't say. I mean, I think you should admit now, if you can't tell us where all that data is and what all its uses are, then it seems you can't, because you've already admitted that entirely commercial market uses.
The control is through both the overriding regulations established within the Data Protection Act and the data sharing agreements that we enter into people, which specifically allow the reuse of data with safeguards with regard to
so you've no idea who the end user is. You've no idea if they're using it properly.
And
there is no audit.
And that is in accordance with the law and the regulations as it stands today.
So no audit, just to be clear, audit isn't going to be possible of all the users and all the end users. The data is out there. You have licensed people to use it and other people to buy it from them. and there is no control over that. It's just out there.
I don't accept there's no control. There's control established in accordance with the law and the regulations that they are
But you're not able to say who is using it and for what they're using it. You're not able to say that. There are end users
because
out
we
there.
have a large range of organisations, and we've been encouraging, and the government policy, all government's policy has been for a long time to encourage the use of this data to advance both the health and social care system in this country and the economy. If, for example, we supply pseudo-anonymised data to a drug company to help them develop a new drug, we do not know the end users beyond that organisation, but that is perceived as being a task and a function that we have. It is done so in a manner which the data is safe and secure and is not identifiable back to an individual. If you wish to change the basis upon which we act, and we absolutely welcome the suggestion that we should submit these to the confidential advisory group, and we've identified a number of cases where we would think their guidance would be very helpful, including in this area, we would absolutely welcome that. But I'm afraid we can't make up the rules that we act by.
So,
Note, we need to go and vote. We shall be back in a quarter of an hour, at 3:45. Thank you very much. I think let's restart. What I'd like to do, if I may, is to put a different framework around the discussion in the committee. We've now got a position where the introduction of Care.data has been delayed by 6 months. And the discussion that we've had so far this afternoon doesn't give me huge confidence that we're not going to be back having a similar kind of discussion in September to the discussion that we were having 6 weeks ago. And I wonder what you're doing to use the time between now and September to ensure that we don't have simply a rerun of the discussion we had 6 weeks ago, and how we can be confident that the proper safeguards will exist, be applied, and the public be confident about those safeguards at the time when we come to the end of this delay period.
With regard to Care.data, maybe just worth pointing out that this is an NHS England programme to which we are a supporter, and the senior responsible officer is Tim Kelsey. So I'm very happy to talk about what our role in that is and what our function is.
Yeah.
I'm not in a position really to give you to answer all your questions in terms of the Care.data programme. You really need to address those to NHS England. But I'm very happy to tell you what our role in this
Go on
is.
then. Yeah.
We have essentially 4 roles in this. One is to provide the technology framework to do it for the extraction and the collection of the data, and that we've already implemented that, and we've run it recently to collect data for QOF payments. We have a second interest in providing the IG framework for that. Once the data is collected and it's passed to us, we will be the data controller, and therefore we will be responsible for ensuring its security and its further use. As you know, the data to be collected is 4 months data from GPs. This would be when it's finally rolled out. The release of that has agreed that IOG is very limited indeed. We have agreed that we would only allow it to be used by NHS England, no one else. And our current arrangement is that they will have access to it only on our premises, so it won't go any further than that at this stage. And we have a third interest, which is assuring the data security. So we are concerned about the transmission mechanisms and making sure that they are secure between the GP suppliers, the intermediary software system, and ourselves. And finally, one of the other interests we have is ensuring that the data that's collected is robust and fit for purpose. We're interested in its statistical resilience and whether or not it actually is of value in demonstrating that it can inform both commissioning and research and other bodies. So those are the 4 roles that we're undertaking. In terms of supporting NHS England, as I said, we are reinforcing our view in terms of the IG security, particularly in terms of the ability of the GPs to feel secure in terms of the process to us, and we are reinforcing our control in terms of data controller or in terms of its further onward transmission.
So the core of your answer around Care.data is that there will be the regime for controlling the use of, the access to, the manipulation of that data will be fundamentally different from data received from GPs from the regime that has been applied up till now to HES data.
The release is much more restricted because that was the agreement was made with the Information and Advisory Group, the IAG, Independent Advisory Group, and that's the basis upon which it has been agreed, and we're very comfortable with that. We think there's a really great advantage in being able to demonstrate that the system works, it's secure, and the data that is brought out and is linked to HES data will have demonstrable value. Recognising that there is, I think, and this point has been made by many people, that there's a real sense of ownership and towards GP data, which is particularly important. It is very sensitive, and so I think taking a step-by-step approach is entirely appropriate.
So, but it's odd, isn't it, that we're talking about the same patients, and we have one regime for controlling the data and controlling access to the data, conditions on which it can be used if it's gathered by a GP. But the same patient, when they go into hospital, has a completely different regime of control around their data when it's generated in the hospital.
It's odd, although of course under the NHS Constitution, any individual has the right to ask their provider, their hospital, to suppress their data. And that's a right set out in the NHS Constitution. In some circumstances...
with respect, I mean, what we're talking about here is the control regime around the use of patient data in anonymised or pseudonymised form, and all the discussion so far has been the extent to which those controls are effective. And you've been seeking to demonstrate to us that you believe that the control regime you apply is effective for HES data, but now we're saying that for GP data, the control regime in the future will be fundamentally different.
At its launch, it will be fundamentally different because that was the basis upon which the Independent Advisory Group agreed to the extraction to go forward. That was the basis, I understand it, that NHS England negotiated with the RCGP, the Royal College of General Practitioners, and the BMA and other representatives. And I think that's entirely appropriate. I think that, and for example...
Can I just interrupt you at that point? Why do you... If the control regime for GP-sourced data is regime A, why is it appropriate for that for the treatment of that data sourced from a GP to be subject to regime A, whereas if it's sourced from a hospital, it's subject to regime B? From the patient's perspective, why is that appropriate? I
agree with that. I think it's a very interesting question. I mean, one of your witnesses at your last session, the gentleman from the BMA, makes the point, a very good point, that there is a particular nature of GP data. It's longitudinal, it's often in much greater depths, it deals with individuals in a very different way than that's appropriate to healthcare data. He made a very powerful argument in your minutes for why GP data had a particular characteristic to it that meant it needed to be dealt differently. And I think that is one of the core reasons for doing this.
You talked about it will be treated differently at its launch. What changes do you anticipate? So in other words, are we actually saying we'll give you additional, or we'll pretend we'll give you additional security until the public we get that information from the public and we get it from the GPs, and after that we'll subject it to different tests? In other words, this is a con job, isn't it? Dick Turpin with or without a mask is still Dick Turpin.
I don't think so at all. I'm sorry. I'm trying to give you complete information. What we have done is agree to a certain set of conditions which I think are entirely appropriate. As you are probably aware, there is considerable pressure from charities, medical charities and researchers actually on the limitation.
And that overrides my privacy?
No, it doesn't override your privacy, because indeed you will have, as you are aware, a right to opt out. And that's entirely appropriate.
Well, we don't have a right.
Barbara,
You do have a right to opt out.
We don't. We have. There actually is no right to opt out in law. The Secretary of State has agreed that any objection will be dealt with, but we do not have a legal right. So if you can't even get that right, then we've got no chance.
Barbara Keeley.
Could I just ask, while we're on GP data and the different ways that is treated, just to ask you about free text. When we had...
I'm sorry, I'm having trouble listening to hearing
free text within GP data and the mining of free text, which is going on at the moment. There are applications, mainly academic, but that's how it starts, with which are extracting data from GP notes, from the free text of GP notes. Now, the Minister was very clear when we had the Care Bill debate in the House that there would be no extraction of free text. But in fact, we've heard from GP witnesses that in fact there is already the extraction of the mining of free text. Because, I mean, we talked about rich data. You know, clearly there's a lot of rich data that's just held in the notes in GP surgeries. And that is apparently not being done with patient consent. The patient consent has not been asked for those applications, so that there is a concern now about that.
We've been very clear, and the Independent Advisory Group published its decisions on the website transparently, that for the extracts using the GP extraction service for Care.data, we will not be extracting those free text notes from GP consultations.
Understand that,
and there will be a limited
you
set.
You said that last time.
Correct. If others are approaching this in a different manner, I don't think that's for me to talk to.
So in fact,
if
so
other
just to be
parts of the
clear
health
then,
system.
just to be clear then, you were talking to the chair then about different regimes exist around different types of data. So there is no regime around that. There is no control of that application. The researchers are mining GP notes for free text just to see if it's useful, and that's happening, and it's happening without patient consent.
Well,
How is that legal?
The HSCIC is not. I can't talk
No,
for how
I
other
didn't.
organisations are.
But we were talking about the
You're in charge.
we were talking about the governance and regimes around. So just to be clear, that's nothing. That doesn't fall within your remit at all, and it won't do. That's just separate and carries on to be so. Yeah.
We don't have jurisdiction over the actions of other national bodies.
Is there that's CPRD, isn't it? Uses. Is there any plan to bring CPRD in under the HSCIC or not?
There are no plans that I'm aware of.
Valerie.
Just for clarity, we do handle data on behalf of CPRD to ensure the pseudo-anonymisation process. So we act as a contractor to CPRD, but CPRD, as you know, is part of the MRHA and not part of us, and it operates under a 251 agreement, which is the regulations which allow it to operate, and it is covered, in fact, by the confidential advisory group. So it is acting entirely under an appropriate regime, but it's not something which is our responsibility.
I'm going to stick to Care.data, but I just wanted to remind you, Mr. Jones, that in your letter to us, you actually knew that the logo was used in 2013. Well, it was used as far back as 2013. You wrote a letter. Anyway.
You asked me when I personally became aware, and I think that was the answer.
Right, and I'm telling you that the logo was used in 2013, I think, which fits with the picture that we're not confident that you can run this whole process. But let's go to Care.data now.
Yes, I'm terribly sorry, but we're being asked. You're being asked.
I want to move on to something else with the greatest respect, Mr. Manning. We've got a very short time, and there's another vote at 5:30.
As help as possible, but you're casting assertions.
No one's casting any assertions.
Not giving us an opportunity to respond.
Well, can you let Mr. Manning respond to that?
Mr. Manning doesn't know anything about it. It's not his letter. Mr. Jones wrote the letter. I was just pointing out that the information, they stole your logo in 2013.
My understanding was they published their report in 2013, but
they used your logo without your permission.
Correct.
Okay. And you said you only knew about it in 2014.
Correct.
Right. So I think, ergo, to use a Michael Gove phrase, what happened between then? Where were you?
Well,
Shall we move on?
Yeah, you've asked a question, and
I was not personally cited on the fact that report had been published and that the incorrect logo had been used.
The organisation that's got our data, and you haven't got a clue.
Right, okay. Now, Valerie...
So, and I suppose that's why we've got to the stage where we have with Care.data and the pause, yet again. So, I just want to know what's happening between now. Is this 6 months? Is that fixed in stone? Or are you waiting for everything to be...
Sorry.
Okay, can I just finish the question? Are you waiting for everything to be put in place and then you will proceed with Care.data?
That is not our decision. I've explained to you what our role in this is. The decision on the nature of the programme, the pause, and what is going to be done in terms of the communication package is one for NHS England and for its SRO. It's not for us.
Okay, well, NHS England aren't here.
Well, we didn't invite them to come. We asked the information centre.
But are you working with them or not?
Yes, we are, but we are working very closely with them. And I've explained to you the role we're adopting.
In your knowledge and what you understand, what's happening. Why don't you tell us what you think is happening about it within the 6 month delay? Is it a fixed term or is it open-ended so that all the problems can be sorted?
I can't answer that question. I don't have that responsibility. You have to address the question.
Is it not fair to record that the introduction of Care.data was delayed for 6 months because there was public concern, substantively because there was public concern about the security arrangements around the handling of existing data by the information centre.
Is that a question?
Yes, it is a question. Is that not the principal reason why?
I think there were a whole series of reasons about the communication process, and there may well have been concerns about security.
And in your relationship with NHS England, have you been asked to address those concerns about security during the 6-month delay?
I'm very happy to talk about that. Yes, we have, and in fact, much more than that. We believe, and we've had long discussions with the Department of Health on this, of very serious, broader concerns about security, not just about Care.data, because of some of the issues I raised earlier. And we will be coming forward in the coming weeks with a series of proposals to significantly increase the stringency and robustness of the process we have around a thing called the IG toolkit, and about a series of measures that we were putting in place with regard to security across the system as a whole, not just Care.data, because we're extremely concerned about the current threats to data security across the whole health and social care system. And we will be coming forward with a series of actions to significantly, as I said, increase our surveillance and increase our measures to attempt to get enhanced level of assurance across the system as a whole.
Okay, let's try it this way. What is your time frame? What time frame have you been given by anyone, Department of Health, NHS England?
As of today, pending any further announcement.
No, as of the time of the pause. Or today, anything, today and the pause.
Well, as of today, we understand that the intention is to proceed in October at the end of the 6-month pause. That may be subject to further announcements by NHS England, further changes.
Right, but you're doing some work on this, aren't you? You've just outlined.
Yes, I explained to you what we're doing.
Right, okay.
We have the technology to enable to do this in terms of extracting it up and running. We've demonstrated it to do with QOF. We are taking measures, and we'll come back to you if you wish to, with regard to what we're going to do to enhance security across the system as a whole. As far as I'm concerned, until there are any further announcements, are planning on the timetable as announced at the time of the pause.
Sorry, I didn't hear the last bit.
Sorry, we're planning on the basis of what has been the last announcement, which is that it will be, I think, in
Okay,
October.
what is your end date then that you're working to? When do you expect it all to be up and running? You having done your work, NHS England having done their work, the Department of Health having done their work, and the Secretary of State having done his work. What end date are you working towards?
The intention.
Have you been talking about that at all?
Yes, I'm sorry, but the intention is that we will take in October. We'll take the first run. That is what was announced at the time of the pause.
Is that the 1st of October?
We haven't decided if it's the 1st or the 2nd.
Right. So it's a flexible. It's not quite 6 months fixed exactly.
We are planning on the basis that it will be delayed for 6 months, and that will be, therefore, at the beginning of October. I can't give you the exact date, and perhaps I couldn't even give you the exact time, but it will be at the beginning of October under the current plans.
Right.
I have to say, I am not the responsible officer of this. There may be further changes and further developments, and you need to address that to NHS England.
Well,
it would be wrong of me to foresee what they may or may not do.
This is what's concerning me even more, because you're now saying that you're not in control of it all, and yet
I'm not in control of it because I'm not running the programme.
Who is?
Mr. Kelsey and NHS England.
Right, and you're completely out of it.
No.
And they right.
But they are the senior responsible.
Please help us. Please help us in the public. We don't know the jargon. We don't know DAG or any of those other things. The majority of people out in the big wide public don't understand all that. You have your meetings behind closed doors. We're not party to it. We are elected by people to ask you the questions.
Yes, absolutely.
Right, and so that's why I'm asking you the question. And please understand that, because last time you were both here, NHS England and HSCIC, answering our question. And so you're here, I don't know, maybe I should address it to Mr. Jones. I just want to know, sorry, do you want to check something? Mr. Jones.
Checking to the original documentation.
So is there, in your discussions with NHS England, you're obviously party to all this, aren't you? You're not completely washing your hands of all of this.
No, we're a
Right.
strong part of delivering the Care.data
And,
programme.
and the reason why I ask that is because if there are concerns that people have, they know they have time. And I want to know whether this 6 months figure there is a fixed time for it, or whether it is flexible. Are you going to make sure that all the system is under control, that everything is in place, transparency, accountability is in place, and people understand what's happening to their data, if they so wish not to opt out, in place by a certain time? Or do they have a certain time that they have to opt out by?
So the systems, as Kingsley mentioned, we have a working date at the moment that will be around the 1st of October. That we would take a first extraction, but that date is subject to the consultations, the discussions, the stakeholder engagement, the advisory groups, the significant engagement which is taking place, led by NHS England. We are the organisation providing, if you like, the technology and infrastructure upon which this will be collected, hosted and analysed. That environment, we have a long history of holding significant numbers of records and processing that. As Kingsley mentioned, we have just successfully extracted the quality and outcomes frameworks for GPs using this GP extraction software, and we are going through a process of rigorously developing the technology, implementing, testing, making best use of this period of time. But as Kingsley said, the decisions about exactly how the communications will be run, how the decisions will be taken, are subject to NHS England's governance and senior responsible officer position, which makes them accountable for the management of the overall programme and the delivery of benefits that come from that investment on behalf of the taxpayer.
And could you help us in terms of whether there are any commitments, contractual commitments, that are in place that means that you have to meet that date of the 1st of October?
I'm not cited on any.
No.
Okay. And should we be asking that of NHS England?
You're perfectly free to do so. I don't see
Okay.
what commitments they would have, but I would be interested to know the answer.
Well, clearly things must have been put in place before the pause.
What did you got in mind?
Contracts. You said you're speeding on to data extraction.
Yeah, for the data extraction,
Yeah.
we, as we talked about at the last select committee, we already have an existing contract with Atos for the provision of that GP extraction software.
Right.
That's been in place for some time. It went live successfully recently with the quality and outcome frameworks extractions, and that provides a framework within which the Care.data GP extracts, as per the independent assurance group specification, will be extracted.
Okay, and can I just, because you mentioned Atos, and can I take you back to the letter that you sent us, just to clarify a couple of things? Firstly, are you confident that they can run this kind of contract, given that they're pulling out of another government contract?
Well, we've I think a good record. I mean, I used to be part of the Connecting for Health regime. We had a good working relationship with Atos running the Choose and Book service, and their delivery and performance on this first extract of the GP extraction software over the last few weeks has been encouraging.
Okay. And can I just turn to your answer? I asked about the cost of Care.data with particular reference to the Atos contract.
Correct.
And then you set it out in 2 different paragraphs. You've given me a figure for the GP extraction service. But what about the Care.data?
I think it's worth pointing out that and Max will give you the detail on this. The contract and the letting of the GP extraction service to Atos and the contracts we entered into with the GP system suppliers for extraction system predate the notion of Care.data entirely.
Sorry, I can't hear you.
Sorry, predated the notion of Care.data. These, in fact, the contract I think was signed in 2012.
Yes.
Well before Care.data had even considered it. It was a strategic development on behalf of NHS Information Centre in terms of renewing a series of products that we were using, or they were using, for extracting data from GP systems for example, for the quality management analytics service and to support QOF. So the Care.data is utilising an investment that had already been made and already committed.
That's
the
what I'm trying to
incremental
get
costs
at,
of doing
yes.
Care.data are very small. They're actually about, I think in 14-15, Max will give you the exact figures in a minute, about £1 million.
Right. I think that's what I'm trying to get at, because it's not clear. So they've already got this contract with the GP extraction service, and Care.data is just going on top of that. So you just said there isn't any additional costs, is that right?
No. The Care.data is obviously a service which involves the collection of information, the processing of information, and the publication and sharing of information. The Atos contribution to that environment is to provide the framework within which we do the data collection. They don't store that data, they don't process that data, but they collect it, and they act as the interface to the GP suppliers. So we already have the Atos contract in place, as Kingsley referred to, and the incremental work for Care.data then is to provide the interfaces to the GP information technology system vendors to allow us to extract that data. So that, if you like, the mechanism by which we ask for that data, they provide a response, Atos then package that and send it into the HSCIC. That cost with the suppliers, with the GP suppliers, is forecast in 14-15 to be around about £140,000.
Is that in your answer? I don't think it's not in your written answer.
No, it's not. I mean that's information which I'm giving you today.
Right. Okay. So, I mean, what I got from the first paragraph is that you hadn't quite costed what Care.data separately from the GP extraction service.
That's what
you can't do that.
That's what we've just done.
That's what we've just done.
Yes.
Right.
Yes. But I've just provided you, I think with the specific answer you were looking for.
Yes, but
the wider costs of over an extended, a 5-6 year period of time for running the Care.data service is in development at the moment. That strategic outline case is being developed and we'll be going through the approvals process in the coming months.
So what is the figure of 1.17 million then?
So that was the cost of the Health and Social Care Information Centre staffing during the to date on supporting Care.data.
Okay.
That's our direct staff costs.
Sorry?
That's our direct staff costs.
Right. Okay. So just turning to what's happening now, do you want me to deal with the patient objection?
Yeah.
Okay. So what's happening, what are you doing now in terms of, are you responsible, I'm still not clear, are you responsible or NHS England responsible for the information that's provided to patients about Care.data?
The ultimate decision with regard to the nature of the objection process will be given to us by direction from NHS England, and the communication package is the responsibility of NHS England. I think that's correct, is it, Max?
That's correct.
So they were responsible for putting out the leaflets or not putting out the leaflets and what's going to happen after
They were
that?
managing that process, yes.
And do they, are they discussing any of that with you? Do you discuss that, how that's going to proceed?
I think the subject of objection is one which we're constantly concerned with. The chairman made a comment about the distinction of using different data in different places. We, and indeed others in the system, including Fiona Godcott, are extremely concerned about the fact that there is no consistency about the nature of objections. And it's a very complex and a very confusing situation across a whole range of different subjects. We are attempting, and we're ensuring the technology is improved to make the objection process easier at the GP end, and we're ensuring that that will be as simple and straightforward as possible. I think that overall, we recognise absolutely that the current position to what you object to, where and when, where not in hospital, where not with a GP, whether or not it's consent with regard to a summary care record or whatever, is confusing. It's technically challenging and difficult. Some of the older systems we have within the health and care social system simply can't handle objections, as we've already said, in the acute hospital system.
What is the process then? I'm just getting, I think we've got the
In
wrong
terms of
people here.
Care.data?
I think we've got the wrong people here. You're saying it's NHS England who are handling all
No,
of
we're
this.
very happy to tell you what the process
So
is.
how
Absolutely, delighted
So
to tell you. But what I'm
outline-
saying is that the decision as to what objection, how the rules with regard to objections are to be set under direction, not by us. But the process, Max, we're
yes.
very happy to tell you about.
So patients have the ability to record two types of objection. The first type of objection objects to any information leaving their GP practice about them, which is detailed about their information to the HSCIC. If they record that objection, and that's by the GP recording a specific code called the read code, and in this case it's an N9U0, and once that's recorded in that patient's record, when the GPES software comes to ask for an extract of that, of the data from that practice, patients who have recorded that objection will not have any patient-level data extracted through that GP extraction software, and HSCIC will not have any of that information which was held in the GP system for that particular patient. What we do have, in order that we can monitor objection rates, is we will extract a count of those people who have expressed a type 1 objection. The second kind of objection that people can record is known as a type 2 objection, and there's again a different particular code that can go into the patient's general practice record, and that is where the patient objects to any information containing identifiable data about them leaving the HSCIC. We will, of course, have to record that objection held against an NHS number to say that this particular person has asked us to respect their request to object to it leaving the HSCIC. So we will extract the fact that this individual has registered that objection with their GP. That is how the objections process functions for the GP extraction of data under the Care.data system.
How will you test that across patient data flows? How are you testing that, whether that's going to work? Are you going to...
we absolutely will have to test it, absolutely. And you know, it strikes me as imperative that we take very seriously our obligation to test these systems to make sure that they work.
And so how are you going to do that?
Well, we will have to identify a set of... I mean, we have, I think, a good history, particularly within the old Connecting for Health world, of implementing very rigorous assurance mechanisms. We have a significant amount of experience in doing that. And as you would expect, we will be doing system tests, module tests, integration tests with fully tested scripts. We do volume and performance testing. We do regression testing. I'd be very happy to give you chapter and verse on that. But it's a very rigorous process, and we will be doing
hospital records.
Well, I'm talking about...
I know what you're talking about, but it didn't apply to hospital records, did it? Otherwise, we couldn't be in the situation we're in.
I'm not sure that
Well,
I understand.
okay, I understand that you're talking about opt-outs from GP records, but you don't apply those kinds of testing, those rigorous things you're talking about. You've just thrown all that information out there to people because you don't know who's...
I think slight confusion here. We apply all these testing processes to everything we do, which is the result, by the way, which is why our service level systems at Spine operate at 99.97% uptime. The record of our ability to deliver high quality technology systems is in the fact that the lights are on and on all the time within the NHS.
You don't know who's got your information, so how can you say that?
And that is entirely inconsistent with the legal position. And if you have any evidence that we have in any way breached our regulations or legal position, I'd be very happy and very keen to have it. But if you please give us some evidence.
Yeah. Could you just give us the timetable for that then?
The process was going over the next 6 months, and indeed, as you were aware...
No, I know it's going over the next 6 months,
yes,
but do you have a much more specific timetable? You're going to hit the 1st of October and say, we haven't got all the way through. Do you have a timetable for this process?
I don't have that with me, but I'd be happy to come back to you.
If you'd like to see the Gantt chart that sets out
Hang
the
a second.
testing, we will happily do it.
Yes.
We need this information. People need this information. So you will come back to the committee and tell us what your timetable for this is.
And if you'd like to come and visit Leeds, we'll take you through the testing regime and demonstrate to you on the ground.
Mr. Manning, can I just explain something? It's not just about a dialogue between you and me and the chair and everything. It's about members of the public outside knowing and feeling confident about
Absolutely, and you are their representative.
Maybe you're used to doing things in rooms, behind closed doors, but, we're here to ask you questions on behalf of the public.
Actually, we don't do things in closed door.
Don't take it personally. It's not about us.
We hold all our board meetings in public, and we have been the first organisation to publish this information ever. Voluntarily, I may say.
Could I ask you a further question about opt-out? Because I've asked questions previously, and particularly of the Minister, and didn't get an answer. It's possible, given what we covered earlier, that you're going to say to me that there's nothing that can be done, but there was a question posed: if a patient wanted to have their records removed, their HES data records removed, as my colleague just said, the data that's already out there, could that be done? But I specifically wanted to ask you about a form.
Sorry, do you want us to answer that point?
No, let me just carry on.
We'd be very happy to.
I specifically want to ask you about a form which is on your website, Data Protection Act 1998, withdrawal of consent to the processing of personal information for secondary care purposes.
Yes.
I mean, it may be that is the answer.
It is.
Okay, because the junk leaflet that didn't get to all households had no opt-out form and made it sound like something which you had to make an appointment with your GP, which was disastrous, I think. Online sources have got an opt-out form, and then there's this withdrawal of consent form. I have to say to you that reading through this form, I think this is intrusive in the extreme, because you've gone from a situation where there's no opt-out form and you say, see your GP, to, on this form, you have to give a lot of information about yourself, including, I have to say, things that I don't think people should be asked for, beyond date of birth, NHS number, if known, and so on, email address, telephone number. I don't see why those things are really necessary. And then it goes on to demand proof of identity, driving licence, passport, birth certificate. It goes on to demand confirmation of address, utility bill, bank statement, credit card statement.
Well,
let me.
I think the problem we have,
let me finish,
because we have a duty of care with
let
regard
me finish.
to record.
Unless you're a commercial company.
No.
Can you just let me finish? Because I looked at this form and I found it difficult, and we've been navigating around this system. Because we get on to, after all of this quite intrusive demands for information, an explanation of what happens if you're requesting your information, your patient information, to be removed anonymised. It says your data will be anonymised rather than removed, but it goes on to say that there's a further step where you can request removal of your records from the NHAIS. And then to say this most damning thing, that if you do that, your GP would no longer wish to have you on their list, and you would not be called for screening for processes like aortic abdominal aneurysm, which is a very serious condition. So effectively saying to people, yes, we can remove your records, but your GP wouldn't want you on his list, and you wouldn't be called for quite serious medical screening. Now, surely there's something that falls short of that. Well, where a person can say, I don't want my records sold to these commercial companies, I don't want my records used by insurance actuaries, I don't want my records used for comparison websites, I just want them used for my care. And I have asked the Minister this, and yet you produced a form which I have to tell you is quite scary. It's quite intrusive and it's quite scary, and says that if you fill it right to the end with and it's quite confusing as to if there are different steps here, that says that your GP would no longer wish to have you on their list, and you wouldn't be called for screening for serious medical conditions.
Shall we deal with the points one by
Please.
one? We have to be very clear about the identity of the individual requesting the removal of this, because it's perfectly possible that we have had identity fraud, that people could seek to get someone else's records removed from the system. And the removal of the record system has a significant impact on, for example, prescribing, on NHS records. So we have to be very clear indeed. The individual requesting the removal of their records is indeed the individual they say themselves, which is why that we ask for proof of identity. And we can't do this simply over the telephone. If you feel, and I'm perfectly happy to take away the fact you feel we may go too far.
Well, I think you do. I don't think you need email addresses and telephone numbers.
But you understand our problem.
Yeah.
We have to know that you are who you say you are to remove your record rather than remove somebody else's record, because it would be fairly devastating if that was the case. We have a duty of care on that. I think that the issue of regard of multiple and what we would call dynamic consent with respect to giving consent for different purposes is one that we're very conscious of, and we think that we need to move in that direction. It is technically challenging to enable us to do that because it is both contextually difficult and technically difficult, but I completely accept that the current consent models are too limited and the objection process is too complicated. We need to be able to make it reversible as well. Now the problem is that, of course, if we have taken you out of our records, then identifying you for screening is very difficult. If you don't exist in our records, it's very difficult to screen, to undertake the risk profiling and the risk to find.
Nobody's going to take that last step, are they? Nobody's going to take the step of saying, and take me out of the systems which, you know, I mean, if you say to people your GP wouldn't want you on their system anymore and you wouldn't be called for screening. But surely, what I was saying is, if there's a step short of that.
The way that we find people for screening is that we check the databases. If, for example, in my case, to do bowel screening anybody over the 60, we write to it. If you're not on our data record because you've asked to be removed, I can't find you. If I can't find you, I can't screen you.
But the question I put to the Minister, and which we don't seem to be getting to, is that I think there's a very strong drive for people saying, I want my individual health records to be used for my care and even for commissioning that care, but not for all these other uses. I think that's a very powerful desire. Why shouldn't people ask for that?
I think that's a very valid argument, and I think that that's one, as I've said before, I think that the current system with regard to objections to consents is confused, it's complicated, it's technically difficult, and we need to have a debate, and indeed Dame Caldecott has raised the same issue. We have clearly got inconsistencies about objections and consent in different places in the system. That partly, in a way, the system has grown up over the years, and partly because we had at the very beginning in the UK, almost actually very different from internationally, a presumption in favour of implied consent. That has been the model that has been accepted for 20 years. Now, I think that there's a case to discuss whether or not, particularly in the cases you suggest, that needs to be reviewed. But that would be a matter of discussion and Parliament, and indeed we think it's another area where...
I genuinely think, given the comments I've had, and a whole variety of comments since we've started debating it here, and we've had debates in the Chamber, that the implied consent model breaks down at the point at which their data starts to be used for marketing purposes. I think we in terms of our seminar, the discomfort that people have, it's different really if your data is being used by researchers, by academics, by people who have built a career and have integrity. I mean, you're effectively allowing data to some outfits that are just a couple of guys, just a couple of people. They're trying to set up a sort of go compare website. I wouldn't be, and a lot of people are not comfortable that their data is used for those things. You say constitutionally you can't make that distinction, but I think that's the point at which you lose confidence in the consent that was always there.
And I recognise that. I mean, as I said before, I'm very happy if you can demonstrate where we have not acted within the current law and the current regulations. In the press release I put out last week, I absolutely recognise that there are significant areas where I believe there should be a greater debate about the use of data and about individuals. I could give you the legal...
How will that be held? How will that debate be held? I agree with you, but how will it be held?
I could give you the legal answer, which is under the law, once your data is pseudo-anonymised, it's no longer your data. I don't think that's an acceptable argument any longer, because I do believe that there are individuals who believe in principle that even if its data is anonymised, it's still their data. It relates to them as individuals. I think that we welcome, and indeed we will ask as soon as the regulation comes into place and CAG or a similar body is put in place, for the ethicists and the public to have a discussion about what rules we should apply in allowing access to what sort of data. And I accept that there may well be individuals who, on principle, irrespective of any other argument, on principle do not want their data used for these purposes. I think we also need to set out the case, the cost and consequences of doing so, because equally I'm under significant pressure to enable support a UK economy, to improve productivity, to be open to new companies entering into the UK business and economy. And this is a discussion...
It's all about money. It's all about making money.
I'm terribly sorry, Mr. Cooper. I'm just explaining the policy frame in which I work. I have two separate driver, one of which is an open data agenda, which is being pursued by all governments over the last decade, which is trying to make as much data available for as many people as possible, in the belief that it will result in significant benefits in terms of improving efficiency within the healthcare system and in the wider economy. Against that is and I understand this, a very principled position, which is about, I don't want my data used for that purpose. I think that is a discussion, a totally legitimate discussion that should be undertaken
in terms
under the new regime.
Have that before or after October?
The position in terms of Care.data is, I've already told you, entirely circumscribed. We've already identified that data is only to be used for very specific purposes. It will not go beyond that purpose.
Just to comment then, and then a question. In terms of where I've seen applications for our hospital data being used in the United States, there were, in some of the comments that were made, there was a view that in terms of open data, we've gone a lot further. There were comments made with the launch of a user of a HES data over there that, you know, liberalisation has gone a lot further. You guys over there in the UK are taking all the chances, which is, to be perfectly honest, that's not a position I think we should be in, but that's just a comment. Can I take you back?
Can I comment
you mentioned
on that?
indeed, but I want to go back to pseudonymisation, and I'm just worried about the time.
Okay, but one of the great richnesses of our system is a homogeneous system, the NHS totality, which means that we are uniquely placed in the richness of our data. All governments have seen this as being the basis upon which we can support and promote a healthcare industry and a pharmaceutical industry, which is the healthcare research industry in this country is worth $5 billion a year, and that $5 billion is critical to the UK economy. It is fundamentally linked to the availability of data. The fact we have that data is critical to the continuation of that research industry in this country. We therefore have to balance issues such as privacy, access, and the support of the industry, and that is a debate that people have to have. But we need to identify the benefits from this data as well as the issues that you have.
Well, let me just take us back to the committee had a question about pseudonymisation, and this was a question we put to Max Jones at the last session. He was, I have to say, pretty dismissive about pseudonymisation at source, and we've covered it a lot more. But as I understand it, there is software available that's already being used for pseudonymisation at source. There are research databases that are being used with data and managing to link successfully data, because I know that that's a driver, the view that data has to be linked. And the view very strongly coming across to us from some people is that pseudonymisation, if done properly and irreversibly, makes the position safer, changes the data disclosure, and changes obligations under the Data Protection Act. It's just safer. I mean, there were a couple of things that I put to Max Jones at the last session. That was one, and the other was the sort of safe havens idea, that you, not denying the uses that you just said, Mr. Manning, but that it could be that the data is only held in one place and applications are run against it. But could you deal with the pseudonymisation at source, because you really were quite dismissive about it in the last session, and there are a number of people out there think that this is one of the solutions.
Well, that was not my intention. I think what I was trying to put across, and I'll try harder this time, is that, you know, as HSCIC we are committed to and see the benefit of pseudonymisation as a technique to try and protect the information about individuals which we hold, and we, as I think I said at the last Select Committee, we do take seriously that obligation, and we take the Information Commissioner's Code of Practice on anonymisation seriously. We, again, as I think I said at the last meeting, the HSCIC have instituted a review of the pseudonymisation techniques which are available. That, if you like, fact-finding phase of that review has now completed, and a draft report is being compiled as we speak. That is going to go to a meeting of a steering group which is being constituted to help to guide the HSCIC in its use of pseudonymisation, both as a tool for the collection of information and for a tool in the publication of information. And I see both uses of pseudonymisation as really very important. That group will have its first meeting, I think it's scheduled for the 2nd of May, so that's coming up very shortly. In no way have we reached a conclusion about whether or not pseudonymisation at source is the right answer or the wrong answer, but I think we will have to take into account both the technical feasibility of implementing such solutions, the costs of doing so, and also the benefits.
Being used,
and
aren't they? They're already being used. When you say technically feasible,
there are applications of pseudonymisation at source at the moment, absolutely, and a number of those people who are proponents of that approach have been invited to take part in this steering group. However, there are, I think, some important questions that we need to ask about how pseudonymisation may impact on our ability to accurately identify individuals and link their records, particularly for data sources which are relatively low in NHS number coverage. And as we start to think further forwards about social care, not just health, not just GP data, and I think GP data itself is particularly has a long history of the IT, use of IT in the management of those records. But we have to take into account the long-term vision and how we might move to a new way of working if that's something that we choose to put forwards. Secondly, we also have to recognise that we, as the HSCIC, have an awful lot of other information. And therefore, when we think about pseudonymisation, we are going to link this data that we collect to other data sources. That's one of the things that the Care.data talks about. And therefore, some of the protections which pseudonymisation potentially gives may or may not provide the same benefits when sending it to a national organisation whose obligation is to collect and link this data. So I think we have to recognise that there are benefits for certain cases, and I think I can see that. But I don't want to prejudge the outcome. So at the previous meeting where I said I was not yet convinced it was the right answer, I think that's a genuine, there are philosophical issues to discuss here. This is not simply, we don't currently do it, so I don't want to do it. It's a genuine interest in getting it right.
If I could make a comment, I found a presentation given at a seminar recently that involved staff of HSCIC, I think, and there's an overhead here which describes why pseudonymisation at source is difficult and says things like it's redundant in a secure, well-governed environment, it's complex and expensive, it provides false confidence. So all the negative things, the view you expressed last time, seem to come from the view of IT managers, so from the sort of technical perspective that's the case. But the next overhead had what were the benefits, and they were all from the point of view of the patient. So without pseudonymisation, you risk substantial levels of patient-citizen objections. Without pseudonymisation, you lose data and devalue your data set. Without pseudonymisation, the GP-patient relationship is damaged and care may be impaired. I have to say, I think the patient reasons are a lot more compelling than the IT management reasons.
And I think there are compelling arguments on both sides of that debate, and that's why we've brought together a steering group with a variety of opinions. For me, one of the key things, though, is also to make sure that when we do our pseudonymisation and we publish that, disseminate, share that information with other organisations, that we're also implementing best practice in the way in which we do that. And we have to have a sense of both expertise but also humility to know that we should be asking other people for their opinions and making sure that we are doing the very best that we and the industry can do in that process. So we already, when we extract information for HES, for example, we make sure that pseudonym is based not only on the recipient of that data, but the recipient and the purpose to which it is put. So I think that's an extra level of provision, and I think I can't remember which health subject member raised it, but we also take a view of seeing how we can restrict that data in the way that we publish it. So you mentioned that we in the case I think you referred to, we provided age, not date of birth. We provided a geographical area, not postcode. We provided, so there are steps which we take to try and protect the information.
It didn't look that difficult to overcome that. I mean, from the examples I've seen, the commercial marketers were putting out there, it looked as if it'd be quite easy to bring in other pieces of data but
it would be entirely illegal to do so, and it would be against the data sharing agreements.
I don't think many members of this committee share your view that that's enough of a penalty. We tried when the bill was going through to make it a criminal penalty, and the government side didn't accept that. Frankly, that's the solution.
The only penalty that works.
Could I answer your point, which I thought was a very interesting point about the safe havens and also the single, the notion of we don't release the data. You may be aware that we've already run an experimental process where we are essentially holding the data and allowing investigators to manipulate the data within our framework. We think this is a very interesting way forward. the process of giving data away on, I don't know if you do it on DVDs any longer, is relatively antiquated. We're therefore in negotiation with talking to the research community, and indeed it may well be a sensible solution with regard to supporting commissioning, where we might well move to, where we may look at the cost and feasibility and move situation where we will effectively provide an analytical service where researchers and others can effectively undertake the research within our data lab. And that's something we think is a very, very good idea. HMRC do it already, and we've looked to that, and also the CMS in the States, which is the equivalent body of ourselves. We think this is very good, and I'm meeting with the MRC in the near future to discuss it for researchers. This would...
Forgive me, I agree with what you're saying right now. I think that's fantastic. Why didn't you do it before you allowed the information out?
Well, because we started in 1988 when it would not have been feasible.
No, this last tranche of information in the last year or so, the information that Barbara's been talking about, the HES information, why didn't you say, well, we'll do it this way, the same way you're talking about now?
Because we inherited the system as it is. The investment required to do this will be very significant. The technical challenges will be very significant indeed. I think that it is something that is very well worth investigating and something we are in the process of doing.
Forgive me, this is like Dad's Army. We've let the cat out the bag here. Can I just ask you a quick question? The Code of Practice. At the last committee you talked about it will be published by the end of September. And you're in the final stage of drafting the code. Why is it taking so long, and when will you produce it?
Maybe I can answer this. When I became chairman in June 3rd, I recognised that this was required. I was presented with a draft of the Code of Practice, which I frankly considered reasonably unreadable from a layman's point of view. We therefore rewrote it, and in so doing, there was a view taken by the Department of Health and their lawyers that the document that we then produced did not meet the constitutional requirements of being a code of practice. What we did do was publish a guide to confidentiality which meets all the requirements of the code of practice. We published that in September last year with the support of the Secretary of State and with the support of Fiona Caldecott. I'm very happy to send you copies of this. It sets out all of the requirements placed upon the system as a whole in a highly readable way. What we've then subsequently done is agree with the Department of Health in terms of the implementation of Caldecott 2 and the Code of Practice to form a whole system centre of alliance on IG framework, which will produce a Code of Practice which will cover the system as a totality.
Will you extract data before that Code of Practice is finalised?
If I may just finish. Okay. Our current plan, timetable on this is, and this is particularly helpful in the context of the changes suggested in the Care Bill and also the work we wanted on security, is that we will publish a draft code of practice for consultation at the end of June for consultation before we proceed with Care.data. And that will take into account the outcome of the consultation that I understand will be undertaken by ministers with regard to the regulations and also to the changes of policy that the ministers will consider with regard to the establishment of accredited safe havens.
Not consultation. Will you have a code of practice actually? Will you actually have a code of practice before you extract data? An agreed code of practice.
Subject to consultation, yes.
Okay. No, can I just
one more, Rosie. Otherwise, we're going to be here all night.
You said you when we talked about asking to opt out, you actually said you're going to monitor objection rates. Why would you do that?
Well, I think the most important reason actually is for me to understand the statistical validity of the data which we've extracted. So it seems to me, for example, one of my team is a head of practice for for statistics within our organisation. We need to understand the extent to which we have a representative population geographically or a statistical size which is meaningful and allows us to still draw useful conclusions and to understand the limitations of that data when we publish it.
Okay, so far we've got if you want to opt out, you're blackmailed because your GP won't want you, and you won't be recalled.
Hang on a second. So, the opt-out that we referred to in the HES data does not affect, and is separate from the opt-out in the Care.data. The comment, I'm afraid, is incorrect.
Okay, that's fine. So if I opt out, can you tell me what the consequences for opting out of Care.data then?
In terms of your care record, we would simply, if you type on Care.data, your data will not be transferred for the purpose of the Care.data program for secondary uses. It won't affect, by the way, the transfer of data for direct care.
Okay.
So it won't impact on any direct service to you as a patient.
Okay, so now let me join the two up, which is what I was trying to do, so forgive me, I wasn't clear. So if I want to opt out of HES, your GP may not want to, why would the GP not want to use you on your list? Opt out of Care.data, well, substantially there's no effect, except that you are enabled to know which GP practices have a higher rate and what sanctions and how will GPs who have a high rate of opt-outs be treated?
I absolutely can't answer that because their contractual relationship is with NHS England, and that's a matter entirely for them. I think one of the reasons we want to know the opt-out rate is because you will want to know it. You will ask us what the opt-out rate is.
So we're blackmailing, in essence, we blackmail the patients and now we're blackmailing GPs.
We're not blackmailing GPs at all, we're not blackmailing patients.
Okay, fine.
By the way, would you like to know what the opt-out rate is on HES?
Well, on
because it's so difficult to be virtually impossible.
There isn't an opt-out rate for Care.data yet, presumably, because it hasn't
No,
happened yet.
we don't know that. But in terms of the number of people who have acted or opt-out, it was 14 over the last 4 years.
Absolutely, because I'm with Barbara. I actually got that form up and looked at it and went, oh my God. I wrote to my GP and said, opt me out straight away from anything you'll do. I'll get back to the rest of it. I didn't go mad about HES. Why? Because you've already released the stuff. So stop sitting there going, oh dear, we've only got 14. You opened the door and threw it out anyway.
All right.
So no point in opting out.
Can I bring us back to the point you made a quarter of an hour ago? That for the future, rather than doing it on DVDs or some other way, you thought there was it would be better if the data to which you were providing access was data that remained under your control.
Well, not only we would essentially create a data lab. In other words, you would effectively rent time on our system.
You create a data room and you'd have to have user identity.
We're already doing that in a system called HISKIT, which we have HDIS. And we're doing that on an experimental basis.
Can I ask you to develop that? What are the kind of controls you think should be applied to people who want to use that kind of data? How do you operate that system now? If I want access to this putative data room to use data for research purposes or for any form of research or other purposes, how do you decide whether that's an appropriate use of that data? In answering that question, can I ask you to reflect on whether the kind of ethics review that exists elsewhere in the clinical world, in the academic world, would be appropriate? Is that the kind of value judgment that you anticipate making in deciding whether somebody should have access to this data room? Or do you simply rely on the proposition that the law says this should be made available to as many, with proper controls on as wide a basis as possible?
If we're looking into the future rather than the situation at the moment, as I said several times, we welcome the proposed involvement of CAG, of companies of this, which would bring precisely the ethical and moral dimension to these decisions, which we think, and we agree entirely, has been absent in the past. So we would envisage that depending upon the nature of the data you wanted or the nature of the process you want to do, whether it was anonymized or pseudonymized, we would apply a series of tests appropriate, and those tests would be advised to us by CAG. The advantage of doing this in a data lab is that we'd have an audit trail, we control access, we control what data was taken out and so forth. It is an attractive prospect. The technical difficulties are significant.
But the technical difficulties are it's possible to overcome them, you feel, for both GP data and HES data?
Well, we're currently, the current service we're offering on essentially on a trial but experimental is in fact it covers HES data.
It does cover HES data, and at the moment the only users of that HDIS service are actually in the public sector, not in the private sector during that trial period. We also make sure that all those individuals who are users have been through an individual training They've come into our training facility and been trained on the site. They've not only usernames and passwords, but also a second factor authentication to ensure that we have identity assured to a higher level. But I think that's something which we should review the experiences of running that. We've been running it for some months now, and we'll want to take that forward, and the discussions which we've had with other government departments that are looking at or have already implemented such kind of facilities, to make sure we take it forward in the right way.
So this data room principle is in effect already being operated
We have
on a trial basis.
We have
Correct.
a small trial on Care.data already up and running, and we're learning from that.
Is it the intention that if the trial is successful, that would be the only way in which you would release data in the future?
I think we're too early to state that. We don't know the scale of the technical challenge and the costs associated with the investment required to do it.
What's the critical path to getting to conclusions on that?
Well, we have a strategic program in place, which in fact the Care.data issue is a subsidiary of a renewal of our data management facility. Mm-hmm. We intend to put that into a business case, strategic case, and application for investment later this summer. And this issue of how we allow access data to third parties will be a critical part of that.
But how is both the technical question of how, whether you release it or whether you provide access to it maintained by you. That's one question, and the other question is the value judgments about who gets access to it.
Yes, and that will be radically changed by the proposed amendments to the Care Bill, mm-hmm. Which will essentially provide us with it will replace essentially the IAG and DAG process. I'm sorry about the Data Access Advisory Group, and it will replace it by a much stronger and much more robust and much more transparent process, which is much more akin, and is the process that's already in place for applications that are made for identifiable data under the Section 251 process. And we very much welcome that, which will mean that essentially the same body that advises on the application to the highest, most sensitive data, identifiable data for research purposes, the same ethics body will be advising us with respect to all our data releases. And I've already identified 4 groups of generic data releases where we think their advice and guidance would be very welcome indeed, and they are the marketing issues, they are the issues of passing data to third parties in government, they are the issues of informatics, information intermediaries, and we would hope that they will be in a position to give us guidance on that within the timescale of the amendments going through the bill.
And if this was the way in which this process went in the coming months and years, would that lose any operational opportunities that might otherwise, any legitimate operational opportunities from the benefits that the research community sees and the service planning community sees from the original from Care.data? Does it do the controls make the operational benefits more difficult to achieve?
There are always going to be lots and lots of people who want to accumulate lots and lots of data in their own boxes. And one of the reasons we're very interested in exploring this idea is because we're getting a plethora of databases being accumulated in universities, in various other places. And that gives us a technical problem because of the transformation errors that arise. These databases, therefore, are changed as they go through time. So I suspect we're always going to have individuals that say, I want to have my particular database constructed on my phone, and we will have to discuss whether or not that will be feasible. There will always be that tension. So my own view is that I think we can overwhelmingly provide the service required both for service planners and for researchers by this type of service, and there are good examples internationally, and indeed, as I've said, I've entered up the HMRC, and I think it's something we clearly need to pursue. And
if NHS England came to you during the summer and said, well, we want to go ahead with Care.data but only on this basis, what would be the impact on the timing of Care.data?
In this particular context, I suspect we may well take this. I mean, as I already said to you, the only access we're going to give to Care.data will in fact be to NHS analysts, and indeed our intention is that they will have to come physically to our building to access the data. So in a sense, we've already taken that one step, and I think that would be a natural progression to try and to extend this process exactly on this pathway.
But so you're saying that the coming physically these days sounds a bit out of date.
I know it's
to be honest,
antiquated,
but
isn't it? But you see, we actually have
we'll
controls
be
on
presenting them
our
with cardboard files next.
No, absolutely. But literally, I mean, if you go to the data center place at HMRC, you are physically and not unable to take paper in or anything like that. We absolutely control physical security. So I know it's antiquated, but the danger is not the technology, it's the people. So it's that sort of level of control.
Okay, but the principle that qualified access to a data warehouse controlled by you is already, you're saying, implicit in the Care.data proposal.
We've discussed it with NHS England, and we are all agreed that it is a very attractive option, which we need to test and see if it meets any objections from those who actually need to see the data, and see if it has any operational impact. It clearly answers a number of the problems that have been raised today, and something we think is well worth pursuing.
Thank you. Graham has been called away to another committee of the House, but wants
I do apologise for missing the bulk of the committee, but just following on from that, and you know, Mr. Manning's response there about it being antiquated to allow data sets, whole population data sets on a DVD, I think it's incredibly risky, if not reckless, to allow individuals, if not in a DVD, whatever format, to take those away when there may be copies made. Now, I don't expect you to comment on my opinion, but just leading on to that, hasn't HSCIC commissioned a report on cyber security?
Yes.
By Sir Ian Andrews, and I think the committee were advised that Sir Ian Andrews was going to report by October. On that basis, would it not be prudent to wait until you have that report on cyber security before we press ahead with the data extraction? Is it your intention to wait for the report on cyber security?
I commissioned that report as soon as I became chairman. We've had Sir Ian's initial recommendations. We're now setting up, in fact, a formal committee of the board. We have no less than 27, I think, actions resulting from that, which we are implementing at the great levels of detail.
Will that report be published, or has it been published? Are these recommendations interim recommendations?
No. I mean, this is about I think we start from the principle that we will never be satisfied with the security levels we can achieve. I mean, we see the threats rising all the time. We will never be satisfied with them. So we are putting in place a substantial strengthening of our own data security.
Resilience, I think.
I'm happy potentially to share the report. Just that I'm concerned of it clearly, because it deals with security, may include matters which we don't want to have in the public domain. But if you'd like, I'm sure we can share it with you on individual, or the committee on an individual basis, but I don't want to go through the detail.
I don't think, if I may say so, it's appropriate to share things on a confidential basis with the select committee. Yeah. I don't think that's... No, I don't think that's appropriate.
Okay. Just going on to how we might restore public confidence in relation to whole population data sets. The general extraction of data from GP records that are, the system that's designed to collect data on request from records that are held by GPs and provide information to those organisations that are approved by the Department of Health or NHS England. Would that model of extraction of extracting that data on request rather than a blanket extraction help to provide greater public confidence in the Care.data system? So doing it on request rather than a blanket extraction.
I think that's an issue very interesting to discuss with our IAG. This process, we have an independent advisory group, and we have a very strong group of individuals who are advising on this. We perceive that will likely evolve in a way which will provide us with ongoing advice on this. There are very strong arguments about people who want particular data sets extracted for different purposes. We're very clear that what gets extracted is not our decision, it is subject to that independent body, which involves both ethicists, patients, the public, and clinicians. And we have abided by their advice and would continue to do so.
You seem to indicate that there was a coming debate around some of the issues we've been talking about, and specifically that you were open to rationalising the opt-out forms. I think, you know...
You mean ours, on our site?
Yes.
No, absolutely. I'll go away and look at it. I mean, I have to say that, I mean, our website is incredibly complicated, to say the least, and I think we all recognise that. It's extremely good if you plough through it, but if you're unlucky, you'll end up downloading 10 million lines of prescribing data.
It's the design of the form, and I think there needs to be a totally separate aspect of the rather frightening prospect of your GP dropping you and you never have...
No, I totally take that away.
I think they need, you know, if there are steps of please remove me from this database, please remove me from that database, but I think it also needs an explanation that it won't be deleted, you know, what the process will be, because I couldn't, you know, we've talked about this a lot and I couldn't entirely...
And you raise a very interesting point. When somebody says they don't want us to hold their record, do we delete it? And if we don't delete it, what do we do with it? Where does it go? So there's some really interesting questions there. I'm very happy to take that away. I think that we need to be much more transparent on that.
But we would like a response on that.
No, that's fine. But it will take us some time, and we will have to think. You know, the technical issues.
Sort of reasonably soon telling us, even if it's only a handling strategy, rather than inviting us to wait for a year. Which
I wasn't thinking about a year.
We might find in a year's time that the nature of the committee has changed.
When you're writing, could you explain to us why a GP may not want you on his list if you opt out? If you could explain that. That would be really interesting to see why...
I'm very happy to do that. I have a suspicion it's because he won't get paid if you're not on our list. You won't appear on the register, and if you're not on the register, you won't get paid.
But it's the way it's phrased, it just looks like a threat. If you opt out,
no, I agree.
Your GP will drop you and you never have any screening.
The language is not...
But that is true. If he's not getting paid, he's not... I mean, it's ridiculous. You cannot threaten people of this country with that.
Right. On that note, I think we'll draw the committee hearing to a close. Yes, no, that's outside the scope of this inquiry, I'm pleased to say. Thank you very much.
Thank you very much for your time.
Thank you.